Hello and welcome to today's talk, Sunday the 20th of November. Now, traditionally in healthcare, what we do is we look at an individual patient. We assess people on an individualised basis and we assess their needs. So we assess, then we plan what we're going to do about it. Then we carry out an intervention. Then we evaluate the effectiveness of this intervention. So we assess, plan, implement, evaluate, all on an individualised basis. Bespoke, individualised patient care is the ideal that I taught for 27 years in the health service and associated academia, as well as what I've always done in my clinical practice, individualised care. For example, just to give one example, my blood pressure strangely went up in 2020. So it had been low all my life, then all of a sudden 2020 I checked it and it had gone up. Strange but true. So I assessed that I had high blood pressure. My diastolic blood pressure especially was a bit high. So the plan was I take some blood pressure medication. I take some amlodipine. The implementation is I take that and I assess my blood pressure from time to time. And yes, thankfully, the amlodipine is keeping my blood pressure under control. It's individualised. But I wouldn't want to say that everyone in the country should take high blood pressure tablets. I certainly wouldn't want to say, because it's good for me, children should take high blood pressure tablets. Everything needs to be planned on an individualised basis. What is right for the individual at a particular period of time, at a particular stage of life, considering particular comorbidities. This is the whole thing that Western medicine really and nursing is predicated on. Individualised care, bespoke to the individual. Now, I'm going to go on now and look at a paper from European paper. I'll just show you the paper first of all. Here it is. Does natural and hybrid immunity obviate, take away the need for frequent vaccine boosters against SARS coronavirus 2 in the endemic phase, is the question. Now, this is available here in the abstract. The full paper is available here. Now, at the moment, there's a charge for this, but I do know that the authors have actually paid to make this open access. So it will be free and open access to anyone within a matter of days, which of course is the ideal for the way that scientific information should be distributed. Now, Stefan Pilz and John P.A. Ioannidis, these are both physicians and professors. We've had the privilege of talking to Stefan on the channel, and a very enlightening interview it was indeed. These guys have both got double doctorates. In America, doctors tend to be called MDs, doctors of medicine. In the UK, most doctors don't have doctorates. An MD in the UK and Europe is a very high qualification, equivalent to a PhD. It's a postgraduate doctoral qualification. So these guys are really highly qualified. And I talked to Stefan, and he was on. This guy is on the ball. He was very, very on the ball. Anyway, the coronavirus disease 2019, COVID-19, has entered its endemic phase. Now, nothing to disagree with there. We are in an endemic phase. We observe significantly declining infection rates due to severe acute respiratory syndrome, SARS-CoV-2. Yeah, the infection rates are going down. We know this. I'm not going to give the full details now, but we know this from Office for National Statistics data in the UK. We know this from Zoe symptom tracker data that we follow closely. So we are where we are now. We are not where we were in 2020, late 2020 or early 2021. We're now on Sunday, the 20th of November, 2022, as we've just said. We have to make decisions on where we are now, I think, is the contention. It is crucial but challenging to define current and future vaccine policy. Nothing to disagree with here. Vaccine policy should be clear and it should be defined in terms of SARS coronavirus 2. I think we can agree with that. We're making no comment on the vaccines themselves. We're just saying the policy should be clear and defined. Always nice to know where you stand. In a population with high immunity against SARS coronavirus 2 conferred by previous infection and or vaccination, yeah, no question about that. I mean, for example, we know from the Office of National Statistics data that the antibody prevalence rate has been over 98%. It's now about 95% because it declines, of course. What we don't know from the Office for National Statistics data of how much of that is vaccine induced and how much of that is natural immunity induced. We've critiqued the Office for National Statistics before on that. Despite our feedback, they haven't changed that policy, unfortunately. Anyway, that's where we're at. Vaccine policy must consider the magnitude of the risk conferred by new infections. I think this is patently true. The virus, SARS coronavirus 2, has evolved, will continue to evolve. We need to look at the risk-benefit analysis in the light of this evolution, I would have thought. Hopefully this will influence future policy. So it's evolving, it will do. How the risks vary in different individuals and population groups. So we need to look in healthcare the risks for different groups and ideally individuals. I take blood pressure medication. Blood pressure medication may or may not, I hope it's not necessary for you. It should be individualised whether you take blood pressure medication or not. And very few children need to take blood pressure medication, thankfully. In fact, I don't think I can ever remember giving blood pressure medication to a child in over 40 years of work. Unfortunately, sometimes teenagers. But children do need it, but it would be a specialised paediatric unit. But normally they don't, thankfully. Normally children are very healthy without blood pressure medication, which of course is great. Blood pressure medication is more appropriate for older people. Usually. It needs to be individualised, of course. Right. How to balance the risks, these risks against the apparent small but existent risks of harms from vaccines. Now, of course, they are saying there are some risks from vaccines. We're allowed to say that, but we have to say that they are small. And Stefan, indeed, and his colleague do apparently say apparently small risk from vaccinations. More evidence from randomised controlled trials is needed. Good luck with that. And continuously accumulating national health data is required. It is. We do have yellow card data in the UK, but sometimes it's a little difficult to report on that. Carrying on with the paper. This is all from this paper here, remember, European Journal of Clinical Investigation. Peer-reviewed, accepted, high-quality scientific writing, in my view, and indeed in the view of the peer reviewers of the European Journal of Clinical Investigation. To inform shared decision-making with people who consider vaccination options, and especially policymakers. Because, of course, we would expect all our policymakers to be driven purely by the evidence. We wouldn't expect our policymakers to be influenced by anything else apart from the evidence. So obviously they'll want to take all the evidence on board and make decisions in accordance with the evidence. Why would they possibly want to do anything other than follow the evidence? Or why would anyone want to do anything follow the evidence for pharmaceutical interventions? We're talking about people's health and well-being here. We have to follow the evidence. So vaccine policymakers should cautiously weigh that vaccination schedules are needed and refrain from urging frequent vaccine boosters unless supported by the evidence. And of course, we would expect them to be fully evidence-based. Now, the key issues. Whether and how to consider natural immunity after SARS-CoV infection and hybrid immunity. So, natural immunity, strangely enough, actually exists. You might not think it from reading certain news outlets, but let me assure you it exists. If it didn't, we'd all be stone cold dead, because we're surrounded by a milieu of viruses and bacteria that our immune system protects us against. When I did my basic biochemistry course, the figure there was 9 billion different types of foreign antigen can be detected by the human immune system. Mind-blowing system. Natural immunity does exist. Whether and how to consider natural immunity, right, it's very likely that the large majority of the global population has been infected with SARS coronavirus 2. So I've been exposed many times. I know that for a fact. I've been exposed very closely to people who've tested positive. I've never tested positive myself when I've had symptoms, but I could, of course, have had a minimally symptomatic infection, and in fact, I'm sure I have. At least once by late 2022. So China's the exception here because they're still messing around with their zero COVID unsustainable, nonsensical policy. People who have never become infected have probably become a rarity. So, but yeah, I agree completely. I mean, is there anyone in the UK who has not been exposed to SARS coronavirus 2? It's possible. It's hard to see how, if they live any sort of moderately sociable life. We've had such high prevalence rates for so long. Basically, it's very likely everyone has been exposed. It is well established that previous SARS coronavirus 2 infection, including a significant and long-lasting protection against infection. Let me say that again. It is well established that previous SARS coronavirus 2 infection induces a significant and long-lasting protection against reinfection. So what the authors are saying here is if you've been infected with SARS coronavirus 2, that's going to give you long-lasting degrees of immunity. Wow. Natural immunity appears to work according to these authors. Wow, imagine that. And even more so against severe COVID-19. So if you've been infected, you're more protected against severe COVID-19. Now, this is such a bold statement. It's such a bold statement. I'm going to have to cross-check it with another reference source. So let's check this evidence to make sure these authors aren't talking rubbish. So we'll go to this article here. In fact, many dozens, of course, we could have chosen from. I've chosen from this one because of the very large numbers involved. Risk of reinfection and disease after SARS coronavirus 2, primary infection meta-analysis. 91 studies, 15 million people, 158,000 infections. Big study. During the first 3 months of the Omicron wave, the reinfection rate reached 3.31%. So whether people had been vaccinated or whether they had natural immunity or both, they were still getting reinfected with Omicron. It was causing a lot of reinfections. But people that had had natural infection, overall rates of severe lethal COVID-19 were very low. So we see that natural infection, we're not saying vaccines don't do this, not at all, but we're saying that natural infection somewhat reduces the risk of reinfection, not that much, but it significantly reduces the risk of getting sick with reinfection, which is what we care about. Significantly reduces that risk. Are not affected by the predominant strain. So this protection, so the 2 to 7 per 10,000. This is remember we're talking about the rates of severe and lethal disease here were very low. So in other words, the first infection of the the first infection of the SARS coronavirus 2 had stopped people getting or gave a large degree of protection against severe illness and death from reinfection. In this case with Omicron. Conclusions. Now remember, we're still on this extra paper here. This is just us fact-checking the evidence. So we're not just taking one paper's word for it. This is the conclusion. A strong natural immunity follows the primary infection and may last for more than 1 year. Strongly suspect it's going to last for a lot longer than 1 year. Suggesting that the risks and healthcare needs of recovered subjects might be limited, which is good news, as hospitals are already busy. Although the reinfection rates considerably increased during the Omicron wave, yes, they certainly did, the risk of a secondary severe or lethal disease remained very low. So the natural infection protecting against severe disease and death. The risk-benefit, we've talked about this so many times, we will need to look at risk-benefit profile of multiple vaccine doses for this subset of the population needs to be carefully evaluated. And of course, given that our governments and chief medical officers and everyone goes on the evidence, and only on the evidence, we're sure they will take this evidence on board. Peer-reviewed evidence. Peer-reviewed evidence. So anyway, back to the first paper. So we're now back to the original paper that we were looking at. So back to this original paper. Compared to vaccination by 2 doses, natural immunity was associated with a significantly higher proportion of SARS coronavirus 2 infections before the emergence SARS coronavirus 2 infections before the emergence of Omicron. And of course, with Omicron, there was more people that had been naturally infected were getting reinfected with Omicron. But when identical times have elapsed since the last immune conferring event. So what they're saying here is that an immune conferring event could be vaccination or it could be natural infection. But with Omicron, it depended on how long before that event took place, because we know that the immunity wanes. But what this evidence, emerging evidence, is showing is that although the risk of reinfection can be reasonably high after natural infection, the risk of severe disease and death and hospitalisation after natural infection has always remained much lower, is the main contention of this paper. So they give a couple of examples. Denmark, little viral spread before 2021. Of course, we followed this at the time. Then there's a massive Omicron wave, ensued in a population that had been widely vaccinated, Omicron infection fatality rate until mid-March 2020. So in other words, Omicron just went through Denmark like a hot knife through butter, despite the very high vaccination rates in Denmark. Lots and lots of infections after vaccination. But the Omicron infection fatality rate until mid-March 22 was 6.2 per 100,000 infections. So that's very low among apparently healthy people 17 to 72 years. Compared to previous infection waves in Denmark, there was a very significant decline in infection fatality rate. Now, of course, what this can't do is pick out why the infection fatality rate was less. Was it protection induced by the vaccines, which at that time hadn't been given that long ago? Was it infection induced by natural immunity, which we now know gives a fairly long-lasting, at least up to 1 year, protection against severe illness and death, and I suspect much longer? Or was it the fact that the Omicron was just intrinsically less pathogenic, or a combination of all those? So it doesn't tell us that definitively, but interesting. Omicron wave in a population with substantial prior exposure to SARS coronavirus 2. So population with substantial prior exposure to SARS coronavirus 2, reinfection less than a quarter of the hospitalisation risk and 1/10 of the mortality. So again, evidence here that it's the exposure to the natural virus, the natural immunity, that is generating the protection against hospitalisation and death. Example from Serbia, 1% of reinfections required hospitalisation, so very low. Case fatality was 0.15, but of course most of the infections aren't picked up. The cases are picked up. The infections are those. So the cases are a small subset of infections. There's many more infections that aren't diagnosed than cases. It only becomes a case when it's officially diagnosed. Accounting for non-ascertained infections, which is what they've just said. This suggests the infection fatality rate for reinfections may be less than 0.05, even in people who've not been vaccinated, due to natural immunity. And of course, as we've learned from Professor Clancy in Australia, the vast importance of mucosal compartment immunity. So when you actually breathe in the virus, that generates immunity in your nose, your mouth, your trachea, the mucous membranes lining the respiratory tract. There's a level of immunity in there with its own antibodies, with its own memory B and T cells, with its own T helper cells, with its own T suppressor cells, with its own antibody producing B cells. The whole works is in there in your mucus. Quite incredible. As well as with natural immunity, you get any virus that's absorbed, and some will be, you get systemic immunity as well. So with natural infection, you get the mucosal immunity and you get the systemic immunity. Vaccines, of course, don't generate mucosal compartment immunity. So there we go. Very reassuring that as we are continuously reinfected during the endemic phase, natural immunity, according to absolutely everything I understand about immunity, and everything I understand about immunity, having talked to recently to professors of immunology, immunity levels can only increase with repeated reinfections. So we can expect natural immunity to carry on increasing. And let's hope this is taken into account by those who decide on the healthcare interventions that are appropriate for populations. But above all, I hope we see decision making going back to the level of the individual, so we can assess, plan, implement and evaluate all healthcare interventions for the specific individual concerned. Thank you for watching.